that you really can't see a difference with respect to lives saved from fatal pulmonary embolism versus fatal bleeding. And hence, this becomes an area literally of equipoise. And it's been particularly problematic, as I'll come to at the end, because the anticoagulant we have is warfarin, which obviously is a very, very effective drug, but is a burdensome drug that's, of course, fraught with major bleeding risk. So the question then, of course, becomes what level of recurrence can we accept in terms of withdrawing anticoagulation? And many experts sort of, and I certainly use this in my own practice, that if I estimate that the patient's risk of recurrence is less than 5% per year, that risk is acceptable in terms of withdrawing anticoagulation. So there really is a very individualized management decision that needs to be made based on trying to understand and estimate the recurrence risk, unprovoked, gender, D-dimer I'll come to, the bleeding risks, patient characteristics, their stability on anticoagulation, on warfarin, what the patient wants, their preferences and values, interference of anticoagulation with their lifestyle, with their athletic activities, how they lead their lives. And of course, now we have alternatives to warfarin, particularly some of the newer anticoagulants. Even aspirin has shown some activity. There are, of course, ways you can estimate bleeding risks, and these are some of the parameters that lead to a higher bleeding risk. But I think in clinical practice, it's very hard to really use these. They're pretty obvious in people if we have them, if they have poor anticoagulant control, if they don't take their medicines, they're obviously not good candidates for long-term therapy. People who have other serious illnesses going on and off antibiotics and so forth. So these are things that are somewhat, I think, intuitive to clinicians, but it's worth keeping in mind some of these contraindications or things that increase risk. So I was asked to speak about the duration in the primary thrombophilia, and here's a list. We've just heard a talk on some of these. And I put in the middle the primary thrombophilia, the 5 hereditary thrombophilia, AT3C and S deficiency, factor V Leiden prothrombin mutation, and rarely dysfibrogenemias. I'm also going to speak a little bit about antiphospholipid antibody syndrome, although it's, of course, an acquired abnormality. And then we have a number of abnormalities on the right-hand side, elevation of homocysteine, mild elevations, elevations in a number of procoagulant factors, decreased tissue factor pathway inhibitor, decreased fibrinolytic activity. I think there's been very nice epidemiology regarding many of these as risk factors, but I don't think, frankly, they're clinically useful. Their biologic basis is uncertain. As I'll come to the primary thrombophilia, there's enough question there of how to use that data in decision making. I think for many of these factors on the right, I just don't think the data can be used in a way that we have evidence as how to use it. And in fact, many of the assays are not well validated in terms of their performance to assess what's normal and abnormal. Well, homocysteine perhaps prominently came on the scene in the 1990s, as we heard about, as a risk factor. And of course, there was a lot of interest because it was one we could potentially modulate by administering B vitamins and bringing down homocysteine levels. But then there were a number of pivotal investigations really asking whether intervention with B vitamins, which did indeed lower homocysteine levels, influenced outcomes. And there were studies on both the arterial and the venous side that really showed no impact from lowering homocysteine levels in people with mild hyperhomocysteinemia. So I guess, my practice really is not to measure homocysteine levels, particularly in the US. About 1998, the wheat supply was fortified with folate, so the population levels go down. And I must say there are also some polymorphisms that have come onto the scene, or there, the MTHFR, and there are others too, which really, I think, really are imposters as thrombophilias. Even if you look at some of the good studies where elevated homocysteine mild levels had a twofold risk, the MTHFR homozygosity really had an odds ratio of about 1.0. So I really call the MTHFR imposters. So these are the percentages of people, particularly in Caucasian ancestry, where you'll find the thrombophilias. This is really the same sorts of numbers we saw from the last speaker. Of course, the wide spread reflects selection bias. If you get families with thrombophilia with a strong family history, you'll get numbers on the high side. If you get unselected people without a positive family history, it'll be quite low. So, one of the questions, of course, especially with the sequencing of the whole human genome, is trying to identify other variants that might be modifiers of risk, whether we can really build on the great advances in the 1990s, the breakthroughs in terms of the factor V Leiden mutation, prothrom mutation. And there's been a lot of work, but unfortunately, the variants that have been found by candidate and GMO-wide screens have found some relatively common variants with very low odds ratios of less than 1.5. The Leiden group went back and looked at this based on 31 different SNPs in the MEGA study, and what did they come up with? They came up with factor V Leiden, the prothrombin gene mutation, the ABO group, which probably really is reflecting or is the same factor that's influencing factor VIII levels, because high factor VIII levels have clearly been shown to lead to an increased risk. One SNP in the fibrinogen gene and one in factor XI. Of course, they didn't find protein C, antithrombin, protein S, because they're relatively rare, and the screening techniques are looking for more common variants rather than more rarer variants. So, what do I consider the hypercoagulable workup in appropriate patients? 5 Leiden testing, or if you screen by APC resistance, genetically test for prothrombin, functionally for antithrombin, functional assays for protein C. I might say that protein S, as we're learning, is the most difficult hereditary thrombophilia to diagnose with certainty. The free protein S antigen appears to be the best assay for looking at this. The functional protein S assays have problems due to technical issues, wide coefficient of variation in the assays. There's also a problem in terms of our understanding of the phenotypes in protein S deficiency. You can measure total protein S antigen as well, because there is a phenotype, the type 3, where there's a low free and a normal total antigen, where we really don't understand the biological basis for that. And then, of course, for antiphospholipid, checking for lupus anticoagulant and cardiolipin and beta-2. And, of course, that's an acquired abnormality in general. Just to emphasize, I think the hereditary thrombophilias are primarily risk factors for venous, not for arterial thrombosis, despite the data that was cited from Prandoni showing that having an arterial thrombotic episode or having atherosclerotic disease confers an increased risk of venous disease and vice versa. It's really only the antiphospholipid syndrome that confers an increased risk for both venous and arterial disease. Let me say just a few words about APLS. I think it is important. Of course, it's heterogeneous, both clinically and diagnostically, in terms of the patient population, in terms of the laboratory criteria, either lupus anticoagulant, elevated levels of beta-2 glycoprotein 1 or cardiolipin, and the presence of thrombosis, which is required to give you the syndrome. And of course, they can be idiopathic, but it's also associated with collagen vascular disease, cancer, infections, and drugs. The clinical criteria are shown here, and the laboratory criteria as well, that the tests must be persistently positive, and the cardiolipin antibodies must be really quite elevated, not just above the reference range, really in the top 1%. But the reason why this diagnosis or this finding is important is because of the evidence that's out there that these people are at higher thrombotic risk than I showed you that data from Padua. They are above the 25% risk at 4 years, such that this particular group, long-term anticoagulation, is felt to be warranted with a vitamin K antagonist. But coming back to the inherited thrombophilias, the 5 ones, they're definite risk factors for first events. There's no argument about that. Some of them are relatively weak, some are a little bit stronger. I think most feel that antithrombin deficiency is probably the strongest of the group in the heterozygous form.